This is Selma Schimmel at the San Antonio Breast Cancer Symposium, joined now by Dr. May-Lin Tao, Co-Medical Director of the Center for Radiation Therapy of Beverly Hills, an affiliate of Valley Radiotherapy Associates and Vantage Oncology. Welcome.
Thank you.
So you've just come from a couple of sessions regarding radiation therapy and breast cancer. This is a multidisciplinary meeting, and we've been talking a lot about medical oncology, but surgery and radiation therapy, radiation oncology are all a major part of the journey for breast cancer patients. What did you take away from the studies?
There were two really fascinating studies that were presented back to back. The first one talked about what we call hypofractionated, or sometimes called accelerated whole breast radiotherapy. And essentially what that is taking what would be considered standard in the United States up until maybe very recently or even today, a 5 or 6 week course of treatment and compressing that over about a 3-week period, which is a huge time saver, of course, and potentially a resource saver for the healthcare system as well.
How is that delivered as far as dosing and frequency when you compress it?
Yeah, so typically it's still given Monday through Friday. It's the same experience from the patient standpoint on a daily basis. It's just the course is given over a much shorter period of time. In fact, the study that was presented not long ago today, the first part of the study, it was called START A and START B, START for standardization of radiotherapy as done in the UK, had a number of schemes that were compared to what's considered standard. So their standard was 5 weeks, that is without what we call the boost portion, and that's the standard in the United States as well still when you just give radiotherapy to the whole breast without the boost, to 2 other fractionation schemes when they were first trying to sort out this issue of how frequently should we give it, what dose should we give it at, to try to get a sense of what was the sensitization of the normal tissues relative to the tumor itself. And they had done some biologic calculations too to give them a starting point to make that determination. That led to the subsequent study, which looked at the more practical issue of, okay, now we're going to give over a 3-week period, and how does that compare to the conventional fractionation, which is given over a couple more weeks.
And when it's given over 5 weeks, versus, or when it's given, let's say, over 3 weeks versus 5 weeks, the dosing per treatment is...
So you give a little bit more dose per treatment. That's why I like to think about, even though people call it accelerated, I like to think about it as kind of compressed. So you're giving more dose. It's a little bit more intense in terms of more dose per day. But the experience, like I said, from the patient standpoint, not only in terms of logistics, but it turns out in terms of the actual physical toxicities that a woman goes through are actually less, although the study was thought to show really just that they were the same or not inferior.
So it makes one think that on a cumulative level, when you have to go 5 weeks, even though the dosing may be lower, the effect may be more difficult because it's for a longer period of time. Compressing it and giving the higher dose doesn't bring with it additional toxicity issues.
That seems to be the case, not only borne out by what was reported earlier today, but also there is a very large experience with similar long-term 10-year follow-up. So we now know about the long-term cosmetic results, as well as, of course, the acute experience from the Canadians that women are probably less taxed by the short-term experience, and that probably has to do with a lot of the back and forth stretching out over a 5 or 6 or 7 week period, but also in terms of their satisfaction with how the breast looks, as well as an objective rater of how the breast looks, which were well done in both this study and the Canadian study, is at least as good, if not better.
How long do you think before this will become a standard of care in the United States?
Well, I think there are a lot of people that would argue that even before this study was presented, based on the Canadian study, which also had a very similar scheme, very similar follow, very similar results, essentially the same, and that was published over a year ago, or presented over a year ago, that it should already be a standard in the United States. There are different pressures in our country, frankly, that drive more prolonged treatment courses. Some of them have to do with the way our healthcare is financed. There are also a lot of skeptics, and that can be thought of as a healthy thing as well too, about how applicable or how generalizable this scheme is to all women. The initial Canadian study excluded women who were very large-breasted with the thought that such a accelerated or compressed scheme may actually be more toxic for women who had very large breasts. There was in their more recent report some suggestion that patients with high-grade tumors may not do as well with this scheme, although neither of those issues were shown in the UK report. So, and my own experience has been that in the community, as we've gotten better and better at controlling the dose, even for very large-breasted women, that both the acute toxicity and the cosmetic result is actually quite good, and that size really doesn't seem to be so much of an issue.
Would size be an issue because of volume?
Yes, so it's an issue of volume, and that's kind of a general principle in radiotherapy, that if you take a large volume of tissue, especially if you try to do it in this accelerated or what I'm calling compressed scheme, you're more likely to have acute side effects. But again, I think in part it's due to technique that we're better able to control the dose. In the old days, we would get unintentional, what we call hot spots, so certain areas of the breast would unintentionally get larger doses just because of the shape of the breast and that it was a mound versus, just an even block of tissue. But that is really less of an issue if you're using modern day techniques. And it doesn't seem to be really a barrier anymore. So Americans, frankly, have fewer and fewer reasons to say, oh, that's really not going to work for my patient.
The other study that was presented deals with intraoperative radiotherapy.
The other study looked at something called intraoperative radiotherapy, which is a sort of an extreme form, if you will, of accelerated radiotherapy, meaning it's just given in one fell swoop, in one setting, and actually at the time of the operation. So it's one dose of radiation applied using a device that actually goes into the surgical cavity with the chest wall protected by a barrier so that the dose doesn't go through into the chest wall cavity.
What is that barrier? What do they use to?
It's a sheet to attenuate the dose so that none of the dose will go beyond the chest wall. That's
right.
One of the advantages actually of the technique, is that you're really able to give highly localized treatment, and you're actually literally able to visualize the surgical cavity and place the device and hence the dose exactly at the area of risk, which is your cavity. That's also a form of what we call partial breast radiotherapy, because only that region, that immediate region, is being treated with radiation. More typical techniques have either used a catheter that's placed at the time of the surgery, and later on a radioactive seed is placed into the catheter. That's probably one of the most commonly used ways in the United States, or to use the external beam radiotherapy and just direct it to that portion of the breast.
How does healing take place when you've had this huge dose of radiation into open tissue?
Yeah, so that's actually one of the concerns that has been raised about this technique. The publications seem to show that, and again, this isn't a widely used technique yet, this is in the hands of people who are basically investigators and who are developing the technique, show that if it's done in their hands anyway, that the complication rate of either infections or seromas or poor wound healing should all be in the single digits. But the interesting thing is, like a lot of sort of new technologies, when it starts to become disseminated in the community, we really don't know how that's going to translate. Meaning, are we going to have such low rates of infection or wound healing? And the investigators themselves would say that those are all things that really need to be attended to. The technique really needs to be well done.
Thank you so much for giving us this perspective and highlighting the advances in the area of radiation oncology. Dr. May-Lin Tao, a co-medical director of the Center for Radiation Therapy at Beverly Hills, an affiliate of Valley Radiotherapy Associates and Vantage Oncology.
Thank you.
Thank you.